Hey guys, so welcome to the Happy Teeth Outreach Teaching channel. So this is aimed for any of our students, our foundation dentists or our undergraduate dental students that just want to have a little bit more knowledge and want to be able to pass those finals or those exams that you will be doing. So this presentation today, I didn't introduce myself. So my name is Lindsay and I am the founder of Happy Teeth. So this presentation is split into two parts. The first one is what we're going to do today. So just click on part 2 if you want to watch part 2. So it is asking the question, antibiotic prophylaxis for our dental patients at risk of infective endocarditis, to prescribe or not to prescribe? That is the question. So by the end of this lecture, you should be able to list the relevant guidelines around managing dental patients at risk of infective endocarditis. You should be able to identify the patients at risk of this and be able to describe how you would implement these guidelines in practice and be able to describe how you would manage a dental patient at risk of infective endocarditis. What is infective endocarditis? So it is infection of the inner surface of the heart, usually the heart valve, and it's usually if someone has got a predisposing heart condition like damaged heart valves, and it is when the bacteria in the blood form a nidus on that damaged heart valve. It's most commonly a bacterial cause, but sometimes it can be a fungal cause, and if it is very rarely a fungal cause, this is actually very fatal. It's important that we as dentists are both able to recognise the signs and symptoms of infective endocarditis, but also that we are able to advise our patients of these signs and symptoms. So these are some of them. So weight loss, it is fever, malaise, it is cough, it is a new heart murmur or an existing heart murmur that is changed in sounds. It is also Janeway lesions, which is painful, hemorrhagic cutaneous lesions on the palms and the soles of your feet. Also, it is splinter hemorrhage just on the nail bed as well. So it is important that we know these signs and symptoms because this is a very serious condition if one of our patients was to get this condition. This is a news article that was just released a matter of months ago, and it is a firefighter that got popcorn stuck in between his teeth, and he tried to get it out but he couldn't. He ended up developing infective endocarditis. I don't know, it didn't say in the story if he had a predisposing heart condition, but you can see in the picture that he has got the Janeway lesions, then painful hemorrhagic cutaneous lesions. And the reason he went to hospital is because he had a fever and a cough. So these are so key for us to know these symptoms and be able to advise our patients if we think that is what they are developing. We're just going to outline the patients at risk of infective endocarditis. An easy way to remember how to identify patients at risk of infective endocarditis is the S.H.A.V.E acronym. So this is easy for exams, it is easy for just being in clinic as well. So S stands for structural congenital heart disease, H is hypertrophic cardiomyopathy, then it is acquired valvular heart disease, it is valve replacement, and it is if a patient has had a previous episode of infective endocarditis, although there are some exceptions to this rule. Exceptions to this rule of the structural congenital heart disease includes on the right side of the picture, it includes the atrial septal defect, also in the middle picture if it has got a ventricular septal defect which is fully repaired, or on the left picture if it has got a patent ductus arteriosus which again has fully closed over, or if they've had closure devices which are now completely endothelialized, then they are not, I repeat, at risk of infective endocarditis. But I would just say if you are unsure and if you don't remember these three, then I would just say just contact the cardiologist. But just remember the S.H.A.V.E acronym is the main one to remember of how to identify a patient at risk of infective endocarditis. It's important to be aware that the NICE guidance has actually changed over the years, And in 2008, they said that it was not recommended to give antibiotic prophylaxis for dental patients at risk of infective endocarditis. But then in 2015, things changed with the Montgomery ruling. So that was how we as clinicians need to anticipate what our patient wants to know with regards to the risks and the benefits of dental procedures. So in 2016, the new guidance added one word, okay, and it is routinely. So the antibiotic prophylaxis against infective endocarditis is not routinely recommended, but that one word makes a big difference. We're just going to talk a little bit about the advice that we would give to our patients. We as dental clinicians need to be able to give advice to our patients. And it is important that we outline the risks and the benefits of antibiotic prophylaxis and that it's not routinely recommended. And also encourage our patients to maintain good oral hygiene to reduce their risk, but also outlining to them the signs and symptoms that they need to be aware of, that they should seek help if any of the previous signs and symptoms occur. Also, we need to be able to explain to our patients that actually with invasive procedures such as piercings and even tattoos, that they themselves can pose a risk of infective endocarditis. And it is the most important is to actually document in your notes about this discussion that you have had with your patients. I included these pictures on this slide because they're actually of little cards that the Leeds cardiology team give to their paediatric patients. And I've had a few parents come in and say, hey, this is their little card. And it is a great way just to inform the healthcare professionals that these patients are at risk of infective endocarditis. Also, endocarditis itself actually impacts our treatment planning for all of our patients, and that includes our paediatric patients. For those patients that may have large cavities or even sometimes medium-sized cavities, we may usually opt for extraction, but pulpotomies and pulpectomies are contraindicated because we do not want to risk leaving a tooth that may have infection and may result in infective endocarditis. Also, for those small cavities in the young children in their posterior primary teeth, we would usually opt for, again, if it's a small cavity, a traditional stainless steel crown would be the treatment of choice for those types of caries. This is some more guidance from a huge document from NHS England, their checklist, and it states that adults and paediatric patients should have pre-surgery dental check prior to cardiac surgery. Also for the peds patients, they should be having a specialist dental check at 2 years old as well. And any patient that is admitted to hospital with the signs or symptoms of infective endocarditis should have a dental check in 72 hours to rule out a dental cause. Also, for any of the adult patients that require dental treatment, that we need to be liaising with them surgical teams if they're having cardiac surgery as well. This is a really great website that we can signpost some of our paediatric patients at risk of infective endocarditis, so some of the parents too, if any of them live in Yorkshire and Humber. It just gives them advice on oral health and how to prevent the risk of infective endocarditis. If we think back to the NICE guidelines where they stated that antibiotic prophylaxis for patients at risk of infective endocarditis requiring dental treatment, that it was not routinely recommended. And the reason for that is because it's not shown to be cost effective prescribing lots of antibiotics to prevent infective endocarditis. Also, it's actually shown that regular toothbrushing is sometimes more of a risk of causing infective endocarditis than dental procedures itself. The second reason why antibiotic prophylaxis is not routinely recommended is because of the antibiotic resistance that we all know too well about, and the risk of an anaphylactic reaction, in particular for those patients who have maybe never had antibiotics before, and also the risk of antibiotic associated colitis as well. The third reason is the lack of evidence, because actually when we brush our teeth we create bacteria and that can also cause infective endocarditis. So there's really a balance between the risks of infective endocarditis with dental procedures is quite unknown. This is the Scottish guidelines. In these Scottish guidelines, it states that we as clinicians need to be able to identify those patients at risk of infective endocarditis, and you should already be able to do this with the S.H.A.V.E acronym that we have already mentioned. Also, it outlines how the consent process, that we need to be explaining the risks and the benefits of the dental procedures, of the antibiotic prophylaxis to our patients, and documenting that in your notes. And to also be able to discuss with the cardiologist them high risk subgroups that are at risk of infective endocarditis. The Scottish guidelines outline those high risk groups, and we already know how to identify them with the S.H.A.V.E acronym, but it outlines that it is patients with prosthetic valves, that they've had a previous episode of infective endocarditis, that they have got congenital heart disease. But those with congenital heart disease that have been repaired with a prosthetic material are at risk of infective endocarditis up to 6 months after that procedure, or also they are at risk if there is lifelong regurgitation or a shunt due to them heart valves or due to them repairs. But if in doubt, just make sure that you contact and ask and liaise with the cardiologist. Interestingly, those patients that have got pacemakers or stents are actually deemed not to be at increased risk of infective endocarditis, so therefore they do not need antibiotic prophylaxis. For those patients at risk of infective endocarditis, it's recommended that you discuss with their cardiologist about whether antibiotic prophylaxis is recommended or not. And again, we know with the paediatric cardiology team in Leeds that their stance on this is that they do not prescribe antibiotics for their patients. But if you are in a different part of the UK, or if you're liaising for an adult patient, then make sure you do discuss that with their cardiologist. Also get written correspondence. That is always good medical legally. If it is the patient's first appointment, then you want to already have discussed that with the cardiologist so that if there's any future emergency dental appointments, you know what you're doing. Also, if the cardiologist does advise antibiotic prophylaxis, you still must have that discussion with the patient about the risks and the benefits, because it is also their choice and it is their consent as well. These guidelines state a lot about what we should be documenting in our clinical notes, and that includes the risks and the benefits of all of the treatment options, and the risks and the benefits of the antibiotic prophylaxis, and any specific advice that we have given that individual patient, but also explains that we should be documenting the patient's response and their decision based on that discussion that we had with them. From the guidance, we know that invasive dental procedures for patients in that high risk group actually pose an increased risk of infective endocarditis. So just to give you a definition of an invasive dental procedure, it is manipulation of the dentogingival junction, periapical area, or perforation of the oral mucosa. These are some examples of invasive dental procedures. So that includes obviously incision and drainage of a dental abscess. Also, it is a root surface debridement is deemed invasive, and 6-point perio-charting is invasive as well, although the BP screening technique is not invasive. Also for rubber dams, if they're placed subgingival, or restorations that are subgingival, then they are invasive. Also matrix bands placement are deemed invasive, and interestingly for endodontic treatment, up until the apical stop has been established, it is deemed to be an invasive procedure. So therefore, if our patient was at risk of infective endocarditis and we are carrying out any of these treatments, then we would probably want to discuss with the cardiologist if antibiotic prophylaxis was appropriate or not. So just wrapping up this presentation now. So you should be able to know what infective endocarditis is. You should be able to know what the signs and symptoms are and advise your patients of them signs and symptoms. Also, you should be able to identify very easily those patients at risk of infective endocarditis, so use the S.H.A.V.E acronym. And if in doubt, please liaise with your cardiologist for that patient. If it is a PEDS patient in Leeds, we know that they do not prescribe antibiotic prophylaxis, but obviously in this area, obviously for the adult patients, please do still liaise with the cardiologist. And also make sure that you document everything in your notes. Make sure you document the risks and the benefits of the treatment options, obviously recognising those invasive procedures and the risks and the benefits of antibiotic prophylaxis, because we want to make sure our patients are very informed and that we follow all of the guidance that I've already gone through on this video. Head over to part 2 for some theoretical clinical cases that you may be able to learn from for your future exams.